Hi, Hi, everyone. Thank you so much for joining us today, and welcome to the inaugural Hassenfeld Child Health Innovation Institute seminar. We're really excited that you could join us. Everyone is currently muted, and video will be turned off as well for the seminar. We will take questions at the end of the presentation, so please just submit your questions via the chat function, if you will, or feel free to raise your hand if you have a question or need something. My name is Amy Anthony. I'm the Communications and Outreach Manager for the Hassenfeld Institute. And I'm pleased to be able to introduce today Dr. Phyllis Dennery. Dr. Dennery is a member of the Hassenfeld Institute's Executive Committee. She serves as Pediatrician-in-Chief and Medical Director at Hasbro Children's Hospital, as well as Chair of the Department of Pediatrics at Brown, where she is Sylvia K. Hassenfeld Professor of Pediatrics. Dr. Dennery's research, consistently funded by the National Institutes of Health for 24 years, addresses lung problems and other medical conditions among newborns. She has served on the U.S. Department of Health and Human Services Secretary's Advisory Committee on Infant Mortality and advocated for a Center for Health Disparities while at the University of Pennsylvania. Dr. Dennery, pleased to hand it over to you.
Thank you. I'm very, very pleased today to introduce Dr. Beth McQuaid, who will be the inaugural speaker for the series. Dr. McQuaid is Vice Chair and Professor of Psychiatry and Human Behavior and the Director of the Division of Clinical Psychology and the Professor of Pediatrics in the Warren Alpert Medical School at Brown University. She obtained her Bachelor's of Arts degree in psychology from Yale and a doctorate in clinical psychology, child psychology, from the University of Denver. And after that, she did an internship at Children's National Medical Center and completed a T32 postdoctoral fellowship at Brown. Dr. McQuaid's research is focused on activities around child disease management and adherence to medical regimen in the context of health disparities, which is really the focus of the Hassenfeld Institute for Health Disparities. She conducts all of her research and clinical activities right here at Rhode Island Hospital, Hasbro Children's Hospital, and she's been continuously funded by the NIH as a principal investigator since 1998. She's the co-lead of one of the Hassenfeld Institute's initiatives, the Asthma Initiative, and is the director of the Division of Clinical Psychology in the Department of Psychiatry and Human Behavior at Brown University. In her role as a vice chair, she is the academic leader of the psychologists in the department and responsible for oversight of clinical psychology training at Brown. Big responsibility. Today she will give us her insight about asthma and barriers to medication adherence and the importance of the cultural context. Beth, welcome.
Thank you so much, Dr. Dennery. I want to acknowledge the Hassenfeld Child Health Innovation Institute and the other asthma vertical PI, Daphne Cornice-Mitchell, who's my close colleague and dear friend. The talk today has been supported by so many different projects over the years. The Hassenfeld Institute, the Rhode Island Department of Health, NHLBI, NICHD, and INR. These are some of the representative grants for this work. At Hasbro, we have a lot of work happening in asthma. We have treatment happening at the clinical treatment happening at the Asthma and Allergy Center. Our educational programs through the Community Asthma Program that have been operating since 2000, and our research and interventions that have been grant funded for about 25 years as well. And throughout all of our work, our interactions with families have really informed our educational efforts and what's needed by the community, as well as our research and our intervention questions. So there really are too many people to thank that have contributed to this work along the way, but I do want to give a special shout out to Greg Fritz, who was my mentor when I first came here to Brown and helped me begin my journey in asthma research. So today I'm going to talk about pediatric asthma and what it means to be studying medication adherence and the methods, how an emphasis on individual health behaviors can actually make us ignore institutional and systemic factors, and then what individual, interpersonal, and institutional barriers can affect medication use and contribute to disparities. And then also, because I'm a child psychologist, I've been interested in what asthma medication use looks like across this critical period of development, the transition to high school. And I'm going to include some thoughts, personal thoughts about the lessons that I've learned in doing health disparities research. And I want to start by maybe stating the obvious that, I'm a white woman in an Ivy League institution, as are many of us, doing health disparities research. And with that comes certain responsibilities for humility and for self-reflection. And that is part of the journey of this work for me. Another reminder, as I begin this talk, that race and ethnicity are really social constructs. And I have a few quotes here from some leaders in the field who have done some work in this area. Health disparities research, though, makes us draw sharper distinctions than are truly there, so we can make comparisons and identify inequities. But it is a reminder to us that these are truly social constructs, and they are not necessarily distinct groups. How families identify their race and ethnicity is also critically important in this work. I like the idea of the term Latinx. It seems like it's not gendered, it's inclusive. But there was a Pew Research study done this year that showed only about 1 in 4 Hispanics in the US had heard of the term, and only about 3% were actively using it. And the families that we work within the community do not use that term. And so I won't be using that term, throughout the talk today. Also, years ago, NIH made us all start to record race and ethnicity separately on our inclusion and enrollment reports. And that was important to acknowledge that those are distinct and overlapping, but not the same construct. But one of the things that we found as we started to try to collect data in that way is that our Latino families did not identify themselves in that way. And we tried all sorts of things to get at that so we could do the right reporting, like using sort of more specific terms or allowing people lots of options. But really, in the end, we decided that the lesser of two evils was to have that the race data missing and to let our participants identify themselves and just use the term Latino. So asthma is the most prevalent chronic childhood illness in the United States. It's about 8 to 9% here of US children have asthma. In Rhode Island, it's closer to 10%. And also asthma is more prevalent and more severe among Black and Latino groups. And so if you look at this graph from the CDC, you'll see that green line represents the prevalence of asthma among whites. And the teal line, which is around 7.5%, the teal line represents Blacks, which is around 10.5%. And the blue line actually represents Puerto Ricans, which is close to 15%. And it's interesting. So it's interesting to note that asthma prevalence and severity disproportionately affects Caribbean Latinos. So there's a lot of heterogeneity among the different subgroups of Latinos. And actually, if you are looking at individuals of Mexican descent, the prevalence is actually lower than that of whites who are not Latino. But that's for another talk. But mostly here in Rhode Island, our work has been with Caribbean Latinos. So about 60% of children have persistent asthma, which means that they are typically required to take controller medications every day, typically. Controller medications are inhaled. There is one medication that's used that's an oral medication, a tablet, but they all reduce airway inflammation and they reduce airway responsivity to allergens and irritants. And overall, they improve asthma control. But when you take them, there is no immediate effect on symptoms like there is for quick relief medicine. And so this creates an issue because across diseases, not just asthma, not specific to asthma, people have a very hard time taking medications every single day. And this is true for diseases like diabetes or people with hypertension or antiretroviral treatments for HIV. All of those show that people have a very difficult time consistently taking their medication, and it's close to about 50%, with somewhat higher rates in more life-threatening conditions such as cancer. So my story begins here when I went to graduate school in Colorado. So I have a nice picture of the Rockies here on the left. And I was working at National Jewish Medical and Research Center, which is a respiratory hospital in Colorado that used to be a place that, in the late 19th century and early 20th century, people would go to have a tuberculosis cure to the mountains. At this point, it's been, it's much more focused on asthma and other respiratory conditions. But I was doing, as a psychologist, I was doing some clinical work there and some research, but on the inpatient unit in the emergency department. And I became really interested in how teenagers would sometimes come in through the urgent care and they just had not been taking their medications at all. And what was happening in the family and what kinds of things could be done to promote more effective disease management for these families. This device that is up here on my slide is called a MIDI log, and this is what we were using at the time. And if you're doing work in disease management and adherence, it's really important to have an objective indicator of the behavior that you're measuring. Because if you ask people how well they're taking their medicine, they will always overestimate what they're doing. And we're all kind of guilty of that. So we all think we exercise more than we actually do. We all think we don't eat as much as we actually do. And so it's human nature and social desirability to really say that you're doing more than you do. So this MIDI log is was an early version of a monitoring device that we used. And it was really nice because it would do a date and time stamp of the inhaler use. And it also had a little temperature sensitive thermistor in it, which would indicate whether or not the dose had been inhaled. So we also had that additional piece of information in it. That led to some interesting data where, we would have families come in after being in a research protocol for a month, and we would be downloading their data and looking at it. And a subset of people consistently would be dumping in the parking lot. Like we would call it the parking lot phenomenon, but it'd be like 10 times in an hour. They are just like doing this thing and they're clearly not inhaling it right before they're coming in to turn in their device. So one of the problems that I'll share with you that I realized, as I was continuing in my research career, although not yet, but foreshadowing that really focusing on this clinical encounter makes you focus on the patient as the problem. And so I'm a psychologist. I was interested in health behavior. I was interested in measuring it really rigorously, but in a way that really set us up to be, focusing on the patient interaction and the patient as problematic. And I would present data from, objective monitoring devices and, pediatric grand rounds, and the physicians in the audience would always be, shocked at how little people were doing what they told them to do. But again, that sort of sets up a dynamic that the person is the problem. So I was looking, if you look at sort of this flow chart, sort of my 2020 hindsight, I'm thinking now more about how medications needing to be prescribed and then accepted and then filled by the individual and then taken as directed. So I was really, focusing on that final box and what people were doing and trying to predict that behavior. So, in my vision or my version of the world at that point, I was interested in this idea of adolescence and the transition to adolescence being a period for disruption of disease management. And so I had this idea that what would happen would be, as teenagers, as children turned into teenagers and parents started to kind of step back and let them do more disease management, that the youth would stop doing it, and that was sort of where things started to fall off the rails. And so I wrote a grant about this and got some funding, was really interested and started studying this. And so what we found from our early work was that, not surprisingly, teenagers took less medicine than younger kids. So interestingly, they knew more about asthma. They were more responsible, meaning that they were given more responsibility for their care. They were pretty confident, actually, about their asthma management, and yet they were taking less medicine. And we also found, consistent with other work in this area, that our Latino and Black youth were typically taking less medication than the non-Latino whites in our sample. So I'm a psychologist, and I'm thinking, here's a behavior. I know about behavior change. This is something I should be able to do something about. And, so I designed a brief behavioral intervention that was designed to give the family feedback about adherence. We would do some problem solving. We would set some targets, and we would reinforce increased adherence. And the outcome, I was able to get some funding, a small pot of funding for this as well. And but sadly, we found essentially that yes, we could increase adherence with this intervention. But when we stopped the intervention, back to baseline with the adherence behavior. So, in short, I think the takeaway message was that we could manipulate adherence, but really to have sustained behavior change, was going to require a more intensive effort than that. So in the background of this time, Rhode Island is becoming increasingly diverse. So if you look at this graph, you can see the black line is the growth in the Black population between 1970 and 2020. And the blue line is basically an explosion in the Latino population here in Rhode Island during that same period of time. And so I'm sort of right around here doing this thinking, and these changes are really starting to, affect who we see in our educational programs, who's presenting in the clinic, and where we think we need to be focusing our interventions. So, taking stock of why my first intervention failed, there were a number of clear indicators that we needed to be thinking about. One pretty obvious one is that behavior change requires much more sustained effort and reinforcement. So, and we all know if we're trying to exercise more, we're trying to eat less, and taking medication is similar in that way. If you haven't been doing it, it may require much more effort and reinforcement. Also, I was finding that not everyone believed asthma control or medications worked or were safe. So in the early intervention study, I was junior faculty just out of postdoc. I was doing some of these interventions, and a lot of the families were just not buying that their kids should be on these medications. Language barriers, I think, were also playing an important role at that time too. And if you think about it, controlling medications for asthma most commonly are inhaled corticosteroids. And so if you think about trying to explain, particularly to a family that doesn't speak English, even if there's an interpreter there, that yes, these steroids are safe. No, it's not the same kind of steroid that weightlifters take. And yes, your child has to take them every day for a very long time, you can imagine that is going to be potentially complicated and not effective. Also, there are economic barriers that, in Rhode Island, we do have pretty good insurance coverage for kids. We always have. We have for a very long time. And yet there are economic barriers that affect communities of color that may disproportionately affect medication access as well. So, putting all of this together, I got an R1 funded to look at providing culturally tailored asthma education and feedback about adherence, and getting input from the community, helping with the design of the study, helping with the design of the intervention, and trying to see if we could address medication concerns and improve adherence. So this study we did in partnership with the Providence Community Health Centers, and it was a randomized controlled trial. We enrolled around 230 families, predominantly Latino families and some Black families. And they were randomized to either a standard asthma education, which is our community-based education, which we were already providing, although it was culturally tailored, or education plus behavioral feedback and more specific interventions to address beliefs about medication. So we found that the families learned about asthma. The medications beliefs changed, although only, so we were able to sort of make budge some beliefs and concerns about medications, but only among the Latinos with higher educational status. So the Latinos who had not had any college, who just had graduated from high school or lower, were not buying what we were selling in terms of how these medications were safe. We did find that everyone's asthma pretty much improved, but it was not because we had improved their adherence. So again, I'm still thinking now more broadly about a lot of these other factors that are probably in the earlier cascade of medication adherence that are going to affect disparities and outcomes. So at this point, we had this tremendous opportunity that came about almost by chance. We had a colleague at Yale University who was a health services researcher, and we were having some discussions with him about a measure, and he put us together with Dr. Clarissa Canino at the University of Puerto Rico Medical Sciences Center. And she and Dr. Fritz, with help from the whole team, designed and implemented the Rhode Island Puerto Rico Asthma Center, or the RIPRAC study. So this was a huge undertaking. So we had two protocols. We had data collection happening in two places. We really had to try to standardize everything that was happening across our clinic session, our data collection in the field, our use of devices, both here in Rhode Island and on the island of Puerto Rico. So that was a tremendous effort. And in the end, we had 805 kids with asthma, and we were looking at here in Rhode Island, non-Latino white children and Latino children here in Rhode Island who are of Puerto Rican and Dominican descent specifically, and children with asthma on the island of Puerto Rico. And we were interested in looking at disparities in the diagnosis and management of asthma and barriers to healthcare access. So everything from the initial session, the clinic session with full-on spirometry, et cetera, to indicate whether or not the diagnosis was, the diagnostic process and the outcomes were similar, all the way to the healthcare access part of it. So, I continued to be interested in medication adherence and thinking about it more broadly. Collecting some of the data here was able to look at some of these other factors. So if you think about the universe of children with asthma, as I said before, about 60% have persistent symptoms. And those are the ones who should have controller medicine. Out of those, a subset of them have medicine. And out of those, we could look at how much medicine is actually taken. So we were interested in looking at, what predicted the rates of who had medicine of those who should, and then of those who had medicine, how much were they taking medicine and what was predicting that? Again, the asthma controller medicines. So 530 of the children of the sample had persistent asthma. And we found across both sites that our Latino parents were more concerned about asthma medications, and they were less likely to feel that they were necessary. So we have a standard measure to look at this that's established in the field of health psychology that we had adapted for asthma. And it's basically like a cost-benefit analysis where the family, or the person responded says, how much do I think this is important versus how worried am I about it? So the higher scores indicate that they think there's more benefit and they're less worried about the risk. So the non-Latino whites have the highest sort of benefit compared to risk. Then the Rhode Island Latinos, the next. And then when you get to the island Puerto Ricans, it's almost like a wash for them when they think about what their concerns are relative to how much they think it's going to be necessary to use the medicine to control the child's asthma. So in addition to that, we also collected data on barriers, and the families in Puerto Rico reported more specific barriers like cost and transportation that got in the way of their being able to even obtain the medication in the first place. So these beliefs and barriers predicted who had controller medicine for asthma. So then we were looking at the medication adherence among those who had been prescribed the medication and actually had it. And we had three different objective monitoring devices. One was the MIDI log that I showed you before. We also had for the oral medication, we used an electronic pill bottle with a cap that has a microchip in it that records when the bottle is open and closed. And then there are dosage counters now on discus medications, or dry powder inhalers. So we had these three different ways of measuring adherence among the medications that the families had been prescribed. We were not prescribing the medications and rolling them out and monitoring adherence. We just were naturalistically monitoring what they had been prescribed. And again, we found that there was an overall difference by ethnic groups, such that the non-Latino whites have the highest adherence across each medication compared to the Latinos. It looks like it's sort of staggered in a stepwise fashion, but really the difference is here in between the non-Latino whites and the Latinos. And in terms of what predicted that adherence, we found that not necessarily the difference, but the adherence across the sample. We found that family routines and organization regarding medication use and parental beliefs about medication necessity predicted how much medication was taken. So, we were also interested in complementary and alternative medications, or, natural remedies, herbal remedies. Our qualitative data, from focus groups and also from doing classes in the community, showed that our Latino families were using more natural remedies. So things like herbal teas, aloe vera juice, praying, than non-Latino whites. And so it's kind of intuitive to think that that a preference for natural remedies would be associated to lower adherence to traditional asthma medicine. So we were interested in looking at that. Well, it turns out that that's not the case. In Puerto Rico, actually, use of natural remedies was related to barriers to obtaining medicine, but not related to adherence. So what that means is the more that families were saying they couldn't get the medicine, there were barriers to getting it, transportation costs, the more that they were praying that their child's asthma would be okay, and that they were using other remedies to see what they could do to treat the asthma. And in Rhode Island, using natural remedies was positively related to medication adherence, but only among the non-Latino whites. And so if you imagine what that means, it's more like there are some families who are not doing that much to take care of the asthma, and then there are other families who are saying, "Here, take your medicine, use the Vicks. Here's your take this tea," and throwing sort of everything at the asthma to try to see what they can do to manage it. So another interesting thing that we found was during the time we were doing this study in Puerto Rico, the Medicaid contracts were structured so that physicians received capitated payment that included the cost of medication and specialty referrals. So what this means is that, for example, a pediatrician or a pediatrician's office would get a lump sum to manage the Medicaid patients. And that amount of funding had to cover the medication and specialty referrals as well. And so basically, that structure disincentivized physicians to prescribe controller medications or to refer to specialists, because it would come out of their pocket essentially, or their payment for managing the asthma. The other important piece of information is if the physicians sent the families to the emergency department, the medication would get paid for out of a different bucket. And so it also incentivized physicians to more rapidly send families to the emergency department to get medication, to get treatment and get medications there. So back to sort of my flow sheet here. So we're finding that, at the prescription level, at least in Puerto Rico, the Medicaid contracts were discouraging prescriptions for controller medications. Within the healthcare encounter, there were concerns about medicines that a lot of the families had. When it came to filling prescriptions, there were barriers such as cost and language and transportation that also were important to account for. And then looking at the actual medication adherence, really then that's where it's more about parental concerns as well, but also sort of how the family is organized around managing the asthma and what their routines are around taking medication. So meanwhile, although I was very focused on adherence, we were also busy developing and testing some other disease management interventions. So during that time, and before, Dr. Belinda Borelli and I collaborated on a series of studies that integrated asthma education and smoking cessation for parents of children with asthma, which was really an interesting set of studies. We actually measured the ambient nicotine in the air and provided feedback to the families in terms of cigarette equivalents. So, and then used motivational interviewing to try to motivate cessation. So if you can imagine sitting down with a report saying, okay, we've been measuring, the nicotine in your air, families knew we were doing this. And it's as if your child smoked 4 cigarettes this week themselves. I also continued our collaboration with Dr. Canino because we found that a lot of our Latina mothers had a high degree of depressive symptoms, both here in Rhode Island and in Puerto Rico. And so we integrated some treatment for CBT for depressive symptoms with asthma education to try to improve outcomes. I had the opportunity to also collaborate on a study with the Children's Oncology Group to improve medication adherence in pediatric leukemia with Smita Bhatia. And also in the background, we're continuing with our community asthma programs, our school and home-based interventions. And a lot of the time, those interventions, which are uncontrolled, we're showing pretty good outcomes. And in fact, sometimes those good outcomes, if they were the control condition in our randomized controlled trials, were making it difficult for us to find treatment effects in our efficacy trials. So on the left side, some data from our CASE program, which is spearheaded by Daphne Coynes-Mitchell, which shows that our school-based interventions, which include a class for children, a class for parents, and some school staff education, decreased emergency department visits, improved asthma control, improved asthma symptoms, and and also, I said already, decreased emergency department visits. HARP, which is our home-based asthma program, was also finding some good effects. And both of these programs funded through insurance contracts for some portion of it, but also for a very long time through the Rhode Island Department of Health support and our collaborations with them. Our HARP program, which is home-based intervention, which uses a community health worker model to deliver environmental supplies to teach families about asthma and environmental remediation, we were finding significant improvements in terms of families having action plans before and after HARP and improving asthma control. But I'm also still interested in adolescence, and I start to focus really on the high school transition and thinking about this as a vulnerable period for disease management. So not just thinking about adolescence overall, but thinking about that shift from 8th grade to 9th grade, where everything really changes for kids. So designed another study that was funded through NICHD, looking at how medication adherence changed across this transition and whether or not it was different. This was different for families of color, because I'd begun to question my, I'm going to say Eurocentric vision that in some ways, families would step back and this individuation process would happen and teenagers would stop taking as much of their medications, and thinking that that could really look very different by cultural group. You can see at this point, we're measuring medication adherence again by this is the doser, which measures the date and time of actuation of a metered dose inhaler. We have the electronic pill cap, the MEMS monitor with the track cap that we use for oral medications. And then there's a dosage counter on the discus for dry powder inhalers. And down on the right is Cheryl Copel, who's sort of our unsung hero for all of our adherence work, because if you can imagine all of the data that comes out of all of these gadgets for all of the families and all the cleaning that has to happen pre-analysis, she is the person who is really central to all of that work. So we enrolled almost 100 8th graders with asthma and monitored their medication use for about 2 years. We interviewed them and their families about asthma management, cultural beliefs about use, and really what was happening over this period in 9th grade. So, not surprisingly, we found that medication adherence declined over this time, starting out at around 48%, which seems to be where we always start when we measure it across our studies, right, a little bit under 50% in 8th grade. And then by 10th grade, our teenagers are taking about a third of what's been prescribed. We found lower adherence over time for males compared to females, which was the first time we'd ever found a gender difference in our studies, and for Latinos compared to non-Latino whites and Black youth. So in this study, the Latinos had lower adherence. The Black youth's adherence was similar to that of the non-Latino whites. We found higher family cohesion was associated also with more medication use. So Shira Dunsiger, one of our talented statisticians, helped us with some latent class models, and we looked at, we found that 3 different patterns emerged across this time period. So there was a group, the red group here, that had high adherence. So they did pretty well, like the whole time, 70-ish%. Then the gray group, 45%, never did that great, right? 25% the whole time. But then there was a subgroup that had a decline in medication use. So they started out not that great, but then they really kind of tanked, and there was a steeper decline, like a stronger, a higher slope that was statistically different from between 8th and 9th grade compared to 9th and 10th. So there really was a group where there was this disruption at the high school transition. In the red group, the high group, were more girls and higher family cohesion. The gray group was more Latinos and more boys. And then the blue group, also more boys. So I love this picture because that, I mean, I don't know if it's a young man or a teenager, but he really looks so aggravated at what the doctor is trying to say to him. And interestingly, you know, during this longitudinal protocol, we had really good retention. I think it was 87% or something over 2 years, which was great and due to our incredible staff. But some people some of those kids just stopped taking their medicine completely. They just stopped. And so we were interested. I'm not talking about like the doctor said, okay, things look great, let's back down. They just stopped on their own, basically. And so, you know, we were fortunate to have a Hassenfeld Summer Scholar, Deneva Moncrief, look at this data with us and try to kind of dig into what predict discontinuing medicine without discussing it with your doctor. So by 10th grade, about 23 of our sample had discontinued medicine. So it was a small sample. For this sample, we did find that, you know, the youth medication beliefs predicted whether or not you discontinued or not. And discontinuation was associated with race and ethnicity. 10% of the Black families in our sample discontinued, 19% of the non-Latino whites, and 56% of our Latino families discontinued. So we looked at our family interviews and categorized the different reasons that the families had for discontinuing medication, because pretty early on in the protocol, we realized that this is something we should be probing and getting some more detail about. And most of the time they said, you know, we decided, or he just stopped, or changed our mind. But there were 5 families that said really it was our insurance. And all 5 of those families who cited the insurance barriers were Latino families. Again, small sample, but interesting finding from our Hassenfeld Summer Scholar. One of my colleagues, Barbara Yandasik, who was a postdoctoral fellow in our group, also, you know, did a really interesting study that showed that when families come in and the children speak English and the parents speak Spanish, you know, or don't speak English as well as the children, that it is the case that youth can sometimes be, you know, used as interpreters. Not necessarily that we wouldn't have access to interpreter services, but I think sometimes the family would just go in and say, well, let's see, you know, let's just see how it goes and not ask for an interpreter. And really, there was a lot of lovely qualitative data that showed that a lot of teenagers, you know, and I think probably of any ethnicity that had this language barrier might do the same, but we're editing information in the medical encounter, you know, so that it didn't look like they were doing things like not taking their medicine, and doing things so that they wouldn't look bad. So in terms of, you know, sort of lessons learned about medication adherence, you know, I would say we found that medication adherence declines in childhood into adolescence, and the high school transition is a vulnerable period for some, maybe for boys. Again, our sample is small, and I would want to replicate that, but I thought that was interesting. Cultural beliefs, some of which really have historical roots in grave mistreatment, affect medication use. In our sample, our Latinos did not substitute herbal remedies for traditional medicine. They used them when they couldn't access medicine. And our non-Latino white families used them in conjunction with traditional medicine. So it's different than what one would think. And also focusing, and this is sort of a lesson learned from me as a psychologist, wanting to kind of drill down into behavior and behavior change and measure it as cleanly as I can. You know, there's some risks there. Focusing on individual behavior, you know, doesn't capture some of the interpersonal and systems barriers like language or insurance or implicit bias in the healthcare encounter. And we did not measure that in any of our studies to date, but there's a lot of data that show that influences how much time healthcare providers spend with families and the kinds of recommendations that they give them. So it's no doubt operative here as well. And also structural racism and bias in healthcare financing and healthcare delivery systems can also have a big impact on adherence. So although, I dialed it back from really trying to change adherence behavior in our interventions, I do want to mention a lot of promising interventions that have been developed or are being tested right now. Eris Garrow, who is one of our colleagues in the emergency department, developed an intervention using the emergency department as a point of intervention to increase adherence. David Fideli, who is a postdoctoral fellow working with our group and now is on faculty at the University of Florida. I've had the opportunity to collaborate with him on an mHealth intervention which is delivered more in real time using, ecological momentary assessment and intervention to improve asthma management with teens and parents. Daphne and Clarissa have a very novel intervention, which helps trains high school students, Latino high school students with asthma, to teach Latino middle school students with asthma about their disease, and is looking at if that outperforms our traditional approaches to asthma education. A few other folks that launched out of our lab or in our lab, John Feldman, who designed a really interesting study to both improve symptom perception and improve adherence in pediatric asthma, and Maria Teresa Coutinho, who is very interested in looking at patterns of healthcare use for Black children with asthma and their families and how to support them. And also, I want to say that I think one of the things that I've come to, at this point in my research career is that thinking that efficacy interventions, particularly ones that are behavioral, there's sort of a lot of hubris in developing them. It's sort of like, I think I can come up with a thing that's going to change behavior for this. And really what was happening all along in the community is a lot of our interventions that were evidence-based, we were reaching a lot of families in need, and we were making a lot of change. And so Rhode Island Air, which was initially also supported by the Hassenfeld Child Health Innovation Institute, in terms of getting a lot of community input and the design, and now, in terms of our collaborations across the different Hassenfeld groups, we took the opportunity to really identify the hotspots where asthma utilization was high and deliver the evidence-based interventions that we know work, that are, in school and home settings where families are. So going out to the community and delivering the evidence-based interventions to try to address disparities in a broader way. And also, a shout out to Ronnie Elwey, who's our implementation science collaborator, who has really helped us think about how to evaluate how things work and what isn't working when you're trying to implement evidence-based interventions in the community. So, in terms of what I learned, once the demographics of asthma started changing, it became first an opportunity and then kind of an ethical issue for me to address health disparities when looking at asthma outcomes, because asthma outcomes are really inextricably linked with health inequities, given who is affected by asthma. Also, as I've said, focusing on the healthcare encounter, which, is what I tended to do as a psychologist, and all of you in public health probably wouldn't have made the same assumptions I did, but that really makes you focus on individual factors that drive behavior. And if you're doing health disparities research, that can lead to blame. Listening to participants and their families and valuing their lived experiences is also critical. I really have valued, and haven't been able to do it as much recently, but early in my career was the one delivering a lot of the interventions. I taught a lot of our draw breath classes at the hospital. I was at asthma camp with our families, and really hearing about their lived experiences and their concerns, I think really is what made a big difference in tailoring our interventions to meet their needs. And also, just to say as well, I think it's important to have an ample dose of humility as a health disparities researcher, because the risk of not doing so, is really potentially great harm. So I think working again with the community has been, the most rewarding piece of this work for us, trying to make a difference for children with asthma who are in communities who are disproportionately affected by the disease, has been really, really rewarding. It's just a little snapshot of some more folks in our lab pre-COVID, and just want to thank everyone for the time today, and also a shot of our asthma camp, which has been so fun, also clearly pre-COVID. But I know it's 4:50 something, so I'm happy to be taking questions now. Thank you. Thank you all.
Terrific. Thank you so much, Beth. I thought that was absolutely terrific. Want to remind everyone that we can now take questions. You can put the question in the chat, or you could put in the chat that you'd like to ask a question. We can probably figure out a way to unmute you. I see that we have our, do we have someone in the chat?
I would love to ask a question to Beth, and this was a really spectacular talk. Thank you so much.
Thank you.
A lot. I'm curious, have you had, or has anyone looked at whether the adherence to the medication is also impacted by the concordance of ethnicity or race between providers and?
Oh yeah. So we have not looked at that because to really do that kind of a study elegantly, probably you want to do it like within an HMO or something where you have like a captive population of providers and patients. And so we have not tried to do that. There are some data that show that that racial concordance, I think it helps the healthcare encounter not be as brief. So for example, things like also language. So things like language differences and lack of concordance between providers and patients tends to lead to briefer encounters. But I don't remember if it's actually been looked at specifically with adherence behavior, but it's more about sort of what's happening in the room and in the interaction between the physician and patient.
Thank you.
Yeah.
Great. So we do have a question. I'm going to unmute Selena or ask her to unmute, or Amy, I don't know if you can do. Okay.
Okay. Thank you so much. Of course. Thank you so much for your presentation and kind of mapping the trajectory of how that research developed. I was wondering if there was possibility to look at different ages where that transition might happen. I know you mentioned like the transition from middle school to high school, but I was wondering if maybe like in other cultures or other communities, that transition might happen a lot earlier, like late elementary or middle school.
Yeah, I think I've been interested in school transitions, for different chronic illnesses also, as well as asthma. But I think that there is potential for potentially by culture, but also, for depending on the disease management requirements. So, for example, in food allergy, the transition into kindergarten from being at home is a very significant transition for families. You're right that it could be the case that, in other cultures, if there is a different way of sharing care for asthma within a family, it might be that, siblings are more involved and that some of that transition happens earlier. This is our only, study that is longitudinal enough to look at that. And so we did kind of capture that high school transition specifically, but I think that's a great idea. You bring up a great idea. I'd love to look at that.
Great. We have a couple questions in the chat. One starts with a comment and then a question from Ronnie Elway that I agree very much with. She loved the idea of the young men, boys as deliverers of the intervention, where you brought that up, the high school students with the middle school students. But also question, could you see them developing implementation strategies too, as a way of creating buy-in, serving as champions, and even working with families? Is that something that you might be working on in the future, given your close contact with community partners, rather than just delivering, creating?
Yeah, that's a great idea. I mean, I really love that idea. I mean, one of the things that's kind of related that we've thought about, and again, this is Daphne and Clarissa's study. I'm a co-investigator on it. But for that particular study, the asthma study, is there an impact on the people who are learning to do the training, but the idea of potentially having them serve as champions and having them help with implementation, I think that's brilliant. I think it's great. And it's probably something we should collect some data on while that study is ongoing. But yeah, I think also the community health worker model in some ways, builds on that. So a lot of our, for Rhode Island Air and some of our other approaches, community health workers are members of the community that we're serving. And a lot of them are parents of kids with asthma. And so I think that kind of credibility, I think, is another piece. And getting information from our community health workers, the ones that work with us, often have amazing ideas about what we should be doing to enhance the implementation and the uptake of our interventions in the community. So absolutely.
Great. Another question that came in is, Dr. Daigle noticed that there was better adherence across groups for combination MDI versus single agent.
Oh yeah,
MDI. Any thoughts on why? And she also wondered about adherence and objective subjective assessments of asthma control.
Yes. Okay, great question. So actually, I think that higher adherence on the combination medication is a function of measurement. So we have a lot more data. So each of the medications we were measuring in the different studies, the oral medication, again, montelukast, is once a day. So that tends to have pretty high adherence because it's a once a day pill. We also have somewhat higher adherence for the discus, the combination, as well as, and then, our other medications that are meter dose inhalers tend to be lower. But the discus, we're measuring the dosage counter. So really we just have like beginning to end, how much have they used it. We don't have like the daily, did they use it today? Did they overuse it one day? And we can, truncate it to make sure we don't overestimate for a given day. So part of that is, I think, just a measurement problem. And in terms about, adherence and objective and subjective assessment of asthma control, well, I think that that's a good question. John Feldman's study is one that they are actually looking at adherence and subjective and objective assessment of symptoms in real time. So they could probably answer that question. But I'm not sure if they're related, to be honest with you. I'm not sure. The symptom perception work is something we've been doing for a long time. It was, originally done by Greg Fritz and then continued by others in our lab. And now also, by Marie-Teresa Coutinho and Danielle Atit. But basically, we find that there are people who tend to underestimate their symptoms chronically, those who overestimate their symptoms, and people who are pretty accurate. But I don't think that we found that related to whether or not they do a better job taking their medications. So, but in John Feldman's protocol, that's a question I think he absolutely could ask, because they're collecting the data concurrently. So that's a great question.
Well, I see that we're at the end of the time. On behalf of myself, Dr. Dennery, and Dr. Werner from the Executive Committee of the Hassenfeld Institute, I want to thank Dr. McQuaid for an incredibly informative talk. And there have been lots of comments in the chat of what a terrific talk. Thank you for getting us started in this Hassenfeld seminar series. I also want to thank Amy for her organization and the Hassenfeld family for the funding that makes this happen. Appreciate that. Ellen Block from the family was with us today for this talk. And Please join. We'll be about every 2 weeks. We will be sending out those announcements. And thank you all in the audience for participating. Everyone have a wonderful day.
Thank you all. Thank you so much, Patrick.
Thank you.